Welcome to Module 1 of the Plan of Care training. And I wanted to spend some time here on the care planning life cycle. So you see in this slide, the life cycle for the care plan itself. And we see this as a cyclic in nature concept. Initially, a person comes to the health home program, they're eligible for services, and it's usually due to some sort of crisis or event or a number of crises and events that have accumulated in their life that have put them in their present circumstance. So that crisis or event leads them to link to a health home by means through a referral process. And that's when we start the engagement enrollment process with that person. So that person is outreach. We enroll them into the program. We complete all the paperwork. And then we get into an assessment phase with that person. And that's going to be your comprehensive assessment, your actual plan of care development. And that's when you're really starting to get to know the person. You're asking a lot of questions. You're developing that credibility so that they're willing to share information with you. You're completing all the appropriate consents and documentation so you can speak to different providers and family members and social contacts that they have. So you can start to build, that rapport to build that plan for that person moving forward. And then once that process starts to come together, you're looking at also, what are those person's strengths and weaknesses through that development phase of, getting that credibility, that relationship building. And, you really start to look at how you're going to build on those strengths, right? So you're not necessarily concentrating on the weaknesses with the person. So then as this cycle continues forward, you start to identify goals and priorities based on that person's strengths and areas of improvement or in areas in need, which are also called the weaknesses. And you start to work together to identify things that person wants to work on that's important to them in their life to move forward. And then we get into a reassessment phase again. You've established that plan, you've got that, the situation with the person where you're starting to work on things with them. They're engaging because that's a big piece of this process. And you're looking to identify at that point, how are we doing? How's this person doing to meet those goals and moving through the care planning process? And then that's done, through looking at the objectives that are put forth with that person. So we may, put an objective on hold, or we may complete it. We may extend that objective further for the person so that they can work on things such as, accessing public transportation 3 times a week successfully to get to their employment opportunity, so that they can maintain employment, so that they can successfully pay their rent, so that they can maintain their housing, and the bills and utilities that they have to meet on a monthly basis. So you're really looking to adjust those objectives accordingly to help that person meet those goals. And then you're reassessing again, this is cyclic in nature. You've established the plan, you put forth the parameters, if you will, the objectives that person's working toward for their goals. And then you're reassessing along the way to see how they're doing. And then we're taking inventory, right? So we're taking a step at that point in that plan of care process where we're really, really assessing where that person is, how they're working towards, their goals to better self-sustain, so that they don't necessarily need to be in health home at some point. You really want to stabilize, which would be the next step, that person in their life so that they're not necessarily in need of services any longer. This program is not necessarily designed for a person to be long-term in the program. It's a high-risk population, high-need population that we're working with. So we want to make sure that we're, working to get them to a point where they're needing either a lesser level of service that would be outside of health home care management, or they're able to graduate from the program altogether. And then we're monitoring, how that progress is going towards those goals being met, towards that graduation, towards that step to a lesser level of service if appropriate. And then, that person may wean off the program and they may not be enrolled any longer for a time. And there may be another crisis or event that kicks up that, makes them come forward again to be part of the program because it is a voluntary service. And if that person wants to utilize that service, unless otherwise directed through an AOT order through a court system, they have the ability to decide if they want to be engaged in this program or not. So then, that cyclic process keeps going and it keeps going around as we're working with the person. as we engage with them. So then we start looking at the actual care planning process. I touched on goals and objectives very quickly in that opening slide. So now, as we're starting to engage with that person, we're starting to identify, as we see the photo on the right hand here, what are the different areas of need that that person has, the different areas that that person wants to link to improve, whether it's social determinant of health factor, such as a housing need or a lack of food through food insecurity, or they're ineffectively engaging with medical services. To really identify where those areas in need are for that person to help them link to those services and be more sustainable to meeting those services as their physician may have outlined or as that person so desires. So that's where we start to outline clear goals and desired outcomes that the person wants to achieve. And, as I mentioned, identifying those key services that's going to support that for that person. The other thing we have to do when we're starting to engage with a person out of the gate for health home care management is really establishing those boundaries of what is that person going to do versus what I will do as that care coordinator, that care manager to help them be successful. So you're really looking at their engagement along the way and how you're going to support that. But the goal is to get them to become more responsible, more self-reliant in their own life, more independent. And I often say, to a point where we work ourselves out of our job theoretically, so because we're getting that person so they don't need our support any longer, or they don't need it to the level that they would have when they came into the program. So, those goals, those objectives are going to give you that guide, that compass for that person to work towards that attainment for their goals, keep them on track, those checking points along the way. And then, we support that person through the process. Any changes that come along the way that may change their goal that they want to work on or the intervention that they're working towards on that goal, we work with them to identify based on their strengths, how they're going to get to that and be successful. So then we start talking about the actual, plan of care itself. As we start to get to know that person, we're getting to know their strengths, some of those weaknesses. And we really want to keep in mind as we're starting to pull that information all together of we really should focus at the plan of care on recovery and harm reduction. We want to have a person-centered approach to that for the person as much as possible and really looking at techniques for increasing engagement for them. We want them engaged through this process. The whole point of this program is to get them engaged to a point where they're more self-sustaining, so they can become more successful, get more control in their life decision-making, and moving forward. So some of those theories that we'll discuss today are going to be along self-determination and motivational interviewing. So some techniques to help in that engagement process for folks. And then some other elements that we want to look at when we're developing that plan of care, when we get that assessment phase going initially, you want to look at all the different documents that you're going to do as a care manager, working with that person to pull information from, so that it'll give you a holistic approach in developing a plan. So you have your comprehensive assessment, the eligibility assessment, the HARP assessment, the eligibility screening tool. For a child, it would be the CANS, the Child and Adolescent Needs Assessment for New York, health home appropriateness criteria. Plans themselves could be crisis and emergency plans or HCBS waiver plans. So you're really, as you're doing those plans, you're keeping in mind the information that you're entering and you're collecting through those documents as resources as you're developing the plan of care itself, because you're going to be pulling all that information because it's vital in that plan development. So now I want to touch on, one of those engagement strategies that I spoke of briefly, the self-determination. So the self-determination theory, it's really a theory that looks to a person's ability to make choices and manage their own life. So it's getting that person to act on, choices, and really doing that is working with them to get decision making, make them part of that process. I mentioned a little bit ago about strength-based building. You want to work on building on their strengths in doing so. That parlays into the goal setting piece, getting them to advocate as much as possible for themselves in the process, and really, have a self-awareness of what those strengths are so that they gain more confidence in building them. And it's really a psychological approach toward health and well-being for a person. And it's really, driven to get people to work towards getting more control in their life or more control in their decision making versus us just telling them what they need to work on in order to become more successful in their medication regime, to control their substance abuse disorder. Because without that medication regime and following through with the appropriate, psychiatrist or psychologist and, uh, you know, and the actions that they would have through those meetings, we're not telling them what to do. We're trying to assist them to identify strengths that they're learning about themselves so that they're more able to be successful in that process. So this theory, the self-determination theory, it breaks down to really three categories: the autonomy in making those decisions. So again, getting that person to individualize their ability to make their own decisions, and then get them to get a sense of confidence in making that change. Get them confident in the fact that their transportation, accessing that transportation is going to get them to that job, to get them to pay those bills, to pay rent, potentially get to a point where they can get their enough money saved to get their own vehicle, and be less reliant on public transportation. So it's just building that competence, building that ability to make those decisions, and then getting that person to relate to a sense of being, through social interactions around them, building social capital, really making connections. Also with their providers, healthcare providers, developing relationships with those folks so that they have a sense of belonging, a sense of contact, connection, that'll help them make those decisions to get to a better place in their life. So that was self-determination theory. Now I want to touch a little bit on person-centered planning as a strategy, as well as we're engaging with folks, whether we call them a client, a member that we're working with. But this person-centered planning strategy is really, it's through the Institute of Medicine, this particular definition, which is a highly regarded, accredited organization that's nationally accredited in the country, drives a lot of theory, drives a lot of statistical theory. So a lot of professionals, a lot of educators use the Institute of Medicine for resource and documentation in their studies. But person-centered planning, back to that, it's a highly individualized, comprehensive approach to assessment and services that are founded on the understanding of the person's history, strengths, needs, and vision of his or her own recovery, and includes attentions to issues of culture, spirituality, trauma, and other factors. So there's a lot there, but it's a holistic approach to really getting to know a person. And by doing that, you have to learn all different parts about them as an individual, not just their current circumstance. So there's a plan and recovery pyramid. This comes through the Office of Mental Health, the person-centered workbook. This pyramid really sets the plateau or the basis, if you will, of that person-centered planning process. And you'll see at the bottom of this base, this is the biggest structure, the biggest foundation to this whole process. The person asks for help, whether it be, they're in a mandated program and that help is dictated to them that they need to get it, or they've asked for that help. That's the first step. They've come to the program, they've come to Health Home, they're looking for support, they're looking for help to get to a better place in their life, to address some of those social determinants, some of those substance use challenges that they're facing, mental health challenges that they're facing. They're crying for help, they're asking for help. So then the next level of this pyramid through OMH, through the workbook, saying that you use assessments to get that collaborative relationship going. So you get to understand them. So that goes back to those documents that I was referring to, the comprehensive assessment, developing the CANs, if it's a child that you're working with, you're looking at emergency plans, you're looking at, any sort of assessments that have been completed for that person. You're pulling all that information together, right? So you're starting to get all that documentation. So you're starting to get a more rounded look at who this person is, what their strengths are, what are their needs, what are their challenges, what are their weaknesses. So now that you can start to better get a better look. And then you work with the person to identify or prioritize those goals. So that's the next slide on this pyramid, if you will. So now you're getting all that information. You're starting to see this pyramid that's turning into a funnel now, right? Because you're getting more focused on that person versus that they're coming to you with a blank slate basically, and they're saying, I need help. Well, now we're starting to provide that focus through the funnel a little bit tighter. So you're getting those goals identified, you're starting to identify objectives, and we get into that cycle that I had back on slide one where it's a cyclic nature. You're doing the reassessment, you're doing evaluation, you're establishing the goals, you're looking at the objectives, you're reassessing, and you keep going through that process with the person. And then you look at the strengths and the overcoming of barriers with that person. Work with their strengths through that self-determination process of identifying what they can work on, what they can self-identify, and have confidence in working to build them to a better place. And it could be small things. It doesn't have to be big things that they're working on. It could be very small. And then you're going to work with that person to identify, those small steps that I just indicated, so that they can overcome barriers. Not everybody is the same. Everybody's a different person. We all have our individual challenges, our individual strengths, weaknesses, our uniqueness as an individual. So we really want to, try and work with that person to focus on what's going to help them start to progress forward. And then we look at natural supporters or providers that are going to be able to help that person reach the goal as well. So that's going to be your treatment organizations, your providers, your hospitals, community-based organizations, getting that person linked, a peer resource advocate, potentially if that person had, substance use challenges and they needed to talk with somebody that could help them through some of those challenges, that may have a better understanding of what they might be going through, getting them really linked to the right factors, the right providers that are going to help them be successful and start making positive gains, or have relevance so that they can start to have comfort to work toward positive gains. And then the ultimate goal through this pyramid, as that funnel gets, deeper and deeper to the point, the person attains their life role or their goals. So this theory, this pyramid is, again, the OMH person-centered workbook, person-centered planning recovery pyramid. It's really the basis of how we start, that foundation, as you see on the bottom again. It's really broad. The person comes to you, you're really in an information collecting status at that point, and then you start to build and tighten that relationship, and you get that person working toward that ultimate outcome of obtaining their life goals, or getting to a point in their life where they're sustaining and feeling better about some of the challenges that they're facing. So now I'm going to shift a little bit to what's called motivational interviewing. And this is a technique for member engagement, client engagement, that's really focused to increase motivation, the change that the person, get them to be more willing to engage, get them to, take steps forward. And a lot of times it's for folks that are tough to engage, that really don't want to engage. They don't want to change, but they're involved in this health home care management program, and they're here, so we really want to be successful in trying to take steps to get them to want to engage, get them to move forward to positive change. So that's done through different ways. So we're going to support that person, again, in autonomy and decision-making. So it's going to guide the care manager to help that person clarify their strengths and aspirations, really be an active listener, listen to their concerns, help try and identify ways to boost the person's confidence and their ability to change, and eventually get them to collaborate for a plan of change to move forward. So doing that, you're going to build trust through motivational interviewing. You want to focus on areas that give that person reasons that they want to change, and to get away from that particular behavior or issue that they're holding on to. And it's really to again, help get that person to get a plan in place to help them to move toward that. So there's four different levels of, or four steps for motivational interviewing. And you'll see here on the left, it says engaging and focusing, evoking, and planning. But on the right, you're going to see engaging is on the bottom. So that goes back to the person-centered concept slide through OMH again. You got the person coming to you, right? That foundation of the pyramid is very big, very broad. Well, motivational interviewing, similar in the respect that that engagement piece is very big in the beginning. It's very broad because you got to get to know that person. You've got to get that credibility, that trust with them, so that they're willing to engage with you, right? It's very difficult for somebody to share about themselves and want to trust someone if they have no idea who they are. They don't have the ability to want to trust them because maybe they've had a lot of people come in and out of their life and they haven't had a great response or circumstance or results due to some of those interactions. So engagement is really big. And really it's getting back to get to know the person and understand what's going on in their life. Then the next step is that whole focusing piece. Help that person find an area or areas that they find that's important to them that they want to focus on and to start to work toward change. So you're going to evoke. So this one's important in the motivational interview and piece where you evoke that person, you get them to open up on certain areas. And it's asking certain questions, not necessarily open-ended questions, more specific questions to get them to get more specific responses so you can get them to open up to start talking. And then you're planning. It's a lot of work and effort, as you're all well aware of, doing the job day in, day out. But on the motivational interviewing piece, you see engagement is the biggest point initially. Planning is going to be the smaller piece in the sense that you're going to get all this great information. You're getting this trust from the person. You're getting their buy-in to the point where they're going to be part of the solution to move forward. And then you develop that plan with them where they're going to be engaging. They're part of that process to help move forward. And then really here, I like this. I can't do it. Really, we want to get that person to get to a point where they feel as though they can do it. So you're not asking if the person is motivated, you're asking them what motivates them or him or her. So it's really focused on what's motivating, what's the motivation factor for him or her. So now I want to switch gears just to talk about, what's the health home service provider's role in assisting members or clients when we start to work with them. So we're breaking it down. Really, we're looking at engaging and retaining care. So we want that person to engage, be part of their provider system that they need so that they can get the help that they need professionally, get linked to a community-based organization so they can get linked to services that they are going to find beneficial to help them to address some of those social determinant health factors. For example, if the person is homeless or on the verge of being homeless, get linked to Section 8 or to HUD so that they can get housing in place, to get on a list to help them get housing, help them with an apartment search so that they can get housing, link them to services that are going to help them, get to that point where they're going to be more successful in obtaining the goal that they're seeking. And then you're going to coordinate and arrange for provision of services. So I meant linkage, right? So a big part of that care management role, the care coordination role, is you're linking that person to services. You're providing that coordination effort. You're not the provider of the service. You're not the doer. You're the coordinator, the linkage, the reference point for that person to get them linked to those resources. And then you're going to support that person in their adherence and treatment recommendations. So that could be a coordination effort again, where you're following up and providing reminders, helping them to link to the MAS system to get a ride to that particular appointment for follow through, getting them to follow up with MAS to ensure that ride's going to show up at the time that was initially scheduled. Have that person engage in that process so that they're part of that adherence to the treatment that they're seeking or the service that they're engaging with. And then the service provider is going to work to help monitor and evaluate the needs for that person And some of the examples listed here would be prevention, wellness, medical specialists, behavioral health treatment, career transition, social community services, and peer support. So some of many different types of services or needs that we can help that person link to and monitor the progress for that. And then we're going to help, again, we're building through that motivational interviewing, that self-determination theory, the person-centered planning theory that we talked about, help that person articulate a shared vision for their future. Help them with that. Help them get a better understanding how they're going to get there through that process. And help them through choosing those personal goals. It's that person's goals. It's not our goals. It's not the provider's goals. It's the goal that the person has identified that they want to work on. Help them in making those decisions so that they can be, engaged in that goal when they make the decision on what they want to do. And all the decision-making steps along the way, the problem solving, any adversity that they may be facing and maintaining or following through on certain things, help them to identify through their strengths or certain steps, and they may be baby steps again to obtain success in those areas. And at the end of the day, we want that person to be more self-directed in the sense that they're gaining that self-direction, that confidence to follow through on factors. They have choice. They know they have choice. They know they have the ability and the fortitude to make those decisions, and they are successful in doing that. And lastly, on this module, I wanted to touch on the fact that this is a collaborative process. We want to work with a person, the member, that they're going to work toward graduation from health home services or move to a lower level of care. I mentioned earlier, in theory, we want to work ourselves out of a job. And I say that, tongue in cheek, it's we want to get that person to a point where they don't need our support as much any longer, or they need a lesser level of support. Health home care management is not a long-term program. We want it to be so that it's the high risk, high need population that's being supported. And we get a person to a point where they're not necessarily needed that level of support any longer, and they're able to move on. So, we do that by collaborating with that person, working with them as a team to be successful in that process.